I am going to talk about the esotropia with the disparity between the distant and the near angle. And when it's large hand, we can get benefit from by using the posterior fixation suture. So the distant near disparity in esotropia is considered to be significant when the near angle is more than the distant angle, but by at least 10 prism diopter or more. And this condition sometimes may be the disparity or the gap may be significantly large and poses a challenge to the ophthalmologist regarding the surgical management treatment. And this can be found in patient, the disparity can be seen in the patient with anomalies of accommodation, such as in the patient with a high ACA ratio, or even sometimes in the patient with hypoaccommodation. Sometimes it even may be seen in the patient with normal accommodation, normal high ACA ratio. It's only just an convergence excess esotropia. The question here that can conventional surgery correct both angles, distant and near, and collapse the gap, the bridge that is present or not? Many studies have shown that the result by conventional surgery are not quite encouraging, really. So if we choose a near angle as a surgical target, definitely there is a high risk of overcorrection at distance when the patient looks to the distant fixations. While if we choose a distant angle as a surgical target, again here there is a chance of near significant residual esotropia. So what is the option here? There are a lot of surgical algorithms has been advocated as a treatment option. I will talk about one of them, which is a posterior fixation suture, or it's also called the Federn operation. A Federn is a German word meaning suture. So here, this has been advocated by Cooper, and later on it has been modified by Dideker, and the name has been changed from Federn operation to the posterior fixation suture by von Norden. So what do we do here by this technique or this procedure? We fixate the rectus muscle posterior to the equator, about 12 to 14 millimeter posteriorly by a non-absorbable suture like a Mercellin polyester suture. So the idea here was the technique, how it works, is only weaken the action of the rectus muscle in the field of that muscle mainly. So for example, if we put the posterior fixation suture on the medial rectus muscle, it has been found that the effect in the primary position to be very little, and its main effect will be evident when the eye move toward the adduction toward the field of the medial rectus muscle by creating a new functional insertion. I will show some of the cases that I have did it in the last 2 years. So this child with a partially accommodative esotropia, he has 35 prism diopter of esotropia with distant fixation with the spectacles, and he measured 50 prism diopter of esotropia with the spectacles for near fixation. So the decision here is we chose the distant target, a distant angle as a surgical target, and we add a posterior fixation suture to overcome the near overconvergence. So 5.5 millimeter medial rectus recession has been done both eyes, and posterior fixation suture has been added 14 millimeter from limbus. 2 years after the surgery, he is doing quite well. He is orthotropic with the spectacles for both distances, and he is only esophoric without spectacles, so the angle has been, the disparity has been collapsed significantly. So the patient here was having a high ACA ratio. Another patient with the normal ACA ratio with alternating esotropia, no significant refractive error. He has, if you look to the picture, when the patient has a near fixation, there is quite significant right esotropia, while when the patient has a distant fixation, we can see from the picture that the esotropia is much less. While it measured 25 prism diopter with the prism alternate cavities for distant, and it was 40 prism diopter for the near fixation. So again, the distant angle has been chosen as a target, surgical target, and posterior fixation suture has been added. 1 year after the surgery, there is he has esophoria for the near 7 prism diopter, and he was orthotropic for the far fixation. A patient with the previous strabismus surgery with the residual esotropia, there was 16 prism diopter of esotropia with distant fixation with the spectacles, and he has 30 prism diopter of esotropia with a spectacle for near fixation with the left dissociated vertical deviation hypertropia or of 40 prism diopter. So the plan here, because I have to put a posterior fixation suture to collapse the gap that is about 40 to 50 prism diopter. I've explored first the medial rectus muscle. It was 10 millimeter from limbus, so I've decided not to do any further recession. Just I've added a posterior fixation suture, 70 millimeter from limbus, and I've decided to recess the right medial rectus muscle for distant residual esotropia. And again, posterior fixation suture has been added with inferior oblique anterior transposition, both eyes grade 4 of the left eye because of more DVD. A month after the surgery, there was no significant horizontal deviation at the distant fixation apart from latent DVD of the left eye. And for the near fixation with the spectacles, he measured 6 prism diopter of ESO deviation and latent DVD of 4 prism diopter. So again, a patient with a previous strabismus surgery with the disparity between the distant and the near angle can get benefit from posterior fixation suture. This patient with mild amblyopia, hypermetropia, and this large disparity between the distant and the near angle, as you can see, she has 50 prism diopter of esotropia for distant fixation with the spectacles and more than 70 prism diopter of esotropia for near fixation with the spectacles. So the decision here, even for the distant angle, I have decided to do a little bit to under correction because she has high hyperopic and she has mild amblyopia. These patients are a little bit at the risk of developing overcorrection. 6 millimeter recession has been done, and again, posterior fixation has been done on both medial rectus muscles. 6 months after surgery, she has esophoria for distant fixation, but still there is a residual right esotropia of 16 prism diopter. Still, the alignment are not what we want to make it. It's less than 8 or 10 prism diopter at both distances, but as we can see that the disparity from 13 has been collapsed to less than 10 prism diopter. Finally, the patient with this large disparity between far and near angle, as you can see, when the patient look to near, there is right residual significant convergence, and when the patient look to the distant fixation, depending on the corneal light reflex, someone can say that the patient is ortho. While with the prism alternate cover test, she has 18 prism diopter for the distant fixation and 40 prism diopter for near fixation, with right hypertropia of 10 prism diopter. So again, the distant angle has been chosen as a surgical target. Both medial rectus muscle has been recessed 3.5 millimeter, and posterior fixation suture has been added with the right eye myectomy for hypertropia, right inferior oblique overaction. 1 month after surgery, she has esophoria of 7 prism diopter for near, and she has exophoria of 6 prism diopter. Here, I was scared that this exotropia may converge to more overcorrection due to the exotropia. But a few days ago, she came for follow-up, which became 4 months after surgery. She has esophoria for the near, and she was orthotropic for the distant fixation. We saw the benefit of the posterior fixation suture as collapsing the disparity between the distant and the near angle. But every technique, every procedure has its disadvantage. The disadvantage of the posterior fixation suture is the difficulty to access far posteriorly and fixating the muscle to the sclera. So there is a risk of scleral perforation, and this technique is not adjustable, really. Quickly, other techniques that can be beneficial here, I will mention some of them. Slanted medial rectus recession, it can be useful also. Recess resect procedure or Scott procedure, wide splitting medial rectus recession, polyposterior fixation, augmented medial rectus recession also has been mentioned in literature. I only use slanted medial rectus recession where the disparity is 10 prism diopter between far and more. Other technique, I don't have any experience with it, and summary that the goal of strabismus surgery in general is to align the eyes at both distances and with the minimum number of operation and reducing the morbidity, stress, and cost to the family. So the esotropia or the distant near disparity is challenging condition. So the conventional surgery is not going to work here. Many times the parent and the patient become disappointed when the conventional surgery is done for them, and they become so scared to decide for the second surgery to correct the residual or the remaining unwanted alignment. So the posterior fixation suture is one of the options that can shrinkage the large gap in esotropia and have both good alignment at both distances. And thank you very much.